do you want to make an alteration to that?
No, that's fine. I have a slide deck that I was hoping to share. And it's actually broken up into 3 parts, strangely enough. So it's maybe I can do the first part, take some questions, do the second part, take some questions, and the third part.
Yeah. So if that is all right with you, we'll proceed in that fashion. And please, we are here to basically gather our knowledge, or rather whatever each one of us have, and fulfill it. You understand? So, so it is not actually a discussion, rather more of your talk, interrupted by some questions from certain people.
I am delighted to take questions from people, and even questions that question what I'm saying. I mean, that's what science is to me, is that kind of open discussion. And so please don't hesitate. If you find something you disagree with, don't be shy. It's much better to talk about it than to hide it.
No, we do not know much about the subject. So rather hear your views. We'll raise the question, but probably there won't be enough time for counter questioning or discussion further. Then we can't hear you. So we'll raise a question and then you give your views. And if it goes on, we stick to the topic, then we can't proceed to anybody. We will be wasting our time than learning from you, rather, put it that way.
We are live already.
You understand? So that is the best way. It is more of a learning session. And if you have anyone has any questions, obviously they'll ask, but it will not get into a discussion, because then we won't have the time of listening to you, what you've got to say.
Can you enable host sharing for me so I can share my screen?
Sure.
Thank you.
Professor Bhattacharya, could you go through the slide that we sent you on the mere data that we have got here? Would you like to comment on that?
Maybe I do that at the end of the talk.
Okay. Thank you.
I'm happy to do that. But
may I, Dr. Bose, would you like to introduce Professor Jay Bhattacharya with our viewers? I think that's we should start with that. Yeah.
All right. Shall we start?
Yeah, please.
The first and foremost is the topic of our discussion today is, as you know, we are talking about science and science only. What we gather, a lot of people from media, from political other sources, we gather a lot of stories, but seldom people know the exact science behind it. And that has not been very well projected in the media for reasons which you have highlighted, that this certain things are not projected in the media. So we want to know the real truth, the logic. Maybe the logic has got a lot of ifs and buts. We don't want to get into that. So let me introduce, for the others, introduce Professor Bhattacharya. Just a moment. Let me introduce Professor Bhattacharya. Professor Bhattacharya, better known as Joyanta Bhattacharya or Jay Bhattacharya, is a professor of medicine at Stanford University in States and a research associate at the National Bureau of Economic Research. He directs Stanford's Center of Demography and Economics of Health and Aging. Bhattacharya's research focuses on the health and well-being of populations, with particular emphasis on the role of government programs, biomedical innovation, and economics. Most recently, Dr. Bhattacharya has focused his research on the epidemiology of COVID-19 and evaluation of various policy responses to the epidemic. He is the co-author of the Great Barrington Declaration, along with Dr. Martin Kulldorff. Have I spelled it rightly?
Yes.
And Dr. Sunitra Gupta, regarding issue of this, and which has been supported by millions throughout the world. Now, though it has been supported by millions throughout the world, it has not been accepted by the government and other bodies fully as a way to herd immunity. Now, the basic question here is, today we want to get enlightened on this, is to start off with, since he is the proponent of the Great Barrington Declaration, which was proposed quite a time back. Since then, time has changed. A second wave has come in. Maybe we are anticipating a third wave, yes or no, which you can better answer. And also the vaccine has come in. My question would be, has anything changed from when you proposed the declaration? That's number two, start off with. Has anything changed from that time when you proposed the declaration? I asked this to put in, you will obviously talk about focus protection, which is the main issue. And I would like to also like you to emphasize on its relevance to India. India is a vast country, you know, and it's got we do not have that structured system like your part of the world. But we would like to know, what would you do? Is this focus protection, is it justified, or a stringent lockdown is a better choice for India? So let's start off with that.
Sure. So thank you for that introduction. And let me just start by saying I'm greatly honored to be invited to speak with you. I was born in Chandanagar, and I grew up in the United States, but to be able to speak to people in my home country is an enormous honor. So let me start by just answering briefly your question, and then I'll develop the science behind the answer, if that's okay. The answer is yes. The focus protection idea is more relevant now than it was in October when we wrote it. And that is because the vaccines provide a ideal tool to deliver focus protection. In a time when the vaccines are in short supply, the question is, who do you prioritize for the vaccines? And the principle of focus protection says to prioritize the most vulnerable. And for COVID, that means people who are older, primarily older. Age-targeted vaccination is the way to minimize the death and harm from this disease. So let me back up, and I'll develop that science in a bit. So I have a slide deck to share to sort of go through the science of this. Okay, so the first question you need to answer when you're looking at COVID is how deadly is COVID-19 infection? In the early days of the infection, the World Health Organization put out a report that said, or announced in a press conference actually, that said that 3.4% of people who get the disease, who are infected with the disease, or the cases of the disease, what they said, die from it, 3.4%. That is an enormous, enormous number. If it's truly 3.4%, then we're talking about, if everyone is infected worldwide, hundreds of millions of people dead. And so this is what the basis for which the declaration of a pandemic was made, this 3.4% number. It's also, I think, the basis for which the fear that led to the support for the lockdowns underlies. So we'll talk about that in just a minute, and when we get to it. But what I want to tell you is that this 3.4% number vastly overstates the actual risk of death from infection. So let me tell you about a study that I ran in the early days of the epidemic, in April of last year. So I live in Santa Clara County, California, and it was the home of Stanford University. In the early days of the epidemic, my first thought when I saw that 3.4% number was that it went back to 12 years ago during the H1N1 flu epidemic, also another worldwide epidemic. In those early days of that epidemic, there was also similar numbers like that 3.4%. But then a series of studies were done, a seroprevalence study, which I'll describe in a minute, to actually estimate how widespread the disease was. So the death rate from the disease is very simple. The numerator is the number of deaths, in some sense, where you count the number of people who die with the disease, and the denominator is the number of people infected. In the H1N1 case, in the seroprevalence studies that were done after the initial scare about it, it turned out there were 100 times more people with the infection than were identified as cases, 100 times. And so the initial death rates decreased from as high as 10% in some places down to 0.01%, 0.01%, because the denominator increased. Now, this should not be surprising for a respiratory disease like the flu and also for COVID, because it turns out that COVID has a very wide range of clinical presentations. What gets the news excited and gets me excited also is the set of people who have the severe respiratory infection. And with the viral pneumonia that kills people, ends them in the hospital, puts them in the hospital. It's a deadly, deadly disease. But that's not the typical clinical presentation. The typical clinical presentation ranges from literally no symptoms whatsoever, for about somewhere between 20 to 40% of the population, to mild colds. Those are the vast majority of people. Now, let me tell you how I know that. So in the early days of the epidemic, I ran a seroprevalence study. Seroprevalence study, what it searches for is the antibody evidence in the population that someone has had an infection. You use a test to detect specific antibodies in this case to the spike protein of the SARS-CoV-2 virus that is only turns on for the spike protein. So using this, we did a sample in Santa Clara County and then a population sample in Los Angeles County, which found very similar findings. What we found is that the antibody prevalence in early April of 2020 was 2.8%. That doesn't sound like a large number, but in fact, it was absolutely enormous. At the time, there were about 1,000 known cases in Santa Clara County, 1,000 known cases in Santa Clara County. But if you multiply this 2.8% number times the 2 million people living in Santa Clara County, that gives you 54,000 cases. And there were 100 known deaths at the time. So the case survival rate goes from somewhere in the order of 90% to somewhere in the order of 99.8%. It's not a 3.4% rate of mortality disease. It's more like a 0.2% mortality disease when you take into account the actual size of the denominator. The other important thing, and this is the absolutely most critical thing about the science of the disease. If you know this one fact, then almost all of the right policy follows from it. The fact is that it is the older population that is absolutely at risk from this disease. It's the single most important risk factor. It's not like the flu. The flu actually does harm young people at a high rate. Still, old people who die at higher rates than flu. But the age gradient for this disease is so steep that the youngest people to the oldest people, there's a 1,000-fold difference in the infection fatality rate. 1,000-fold difference in the infection fatality rate. And this is seen in seroprevalence studies that have been conducted around the world. In our own Santa Clara study, actually the age gradient was actually less steep than seen elsewhere. So 2.2% for people who are over 70 versus no deaths at the time for people between 0 and 19. In Spain, the same kind of thing, except for 80 and over, 7.2%. Geneva, Switzerland, 5.6%. There have been also seroprevalence studies in India that have found exactly the same age gradient. By the way, I should say, this 0.2% number of the infection fatality rate is now confirmed by almost 100 seroprevalence studies that have been conducted all around the world. And the World Health Organization has published an article by Professor John Ioannidis, who is a professor here at Stanford, surveying this literature. The median infection fatality rate is somewhere on the order of 0.2%. 0.2%. Now, how do you square the 0.2% with the incredible media attention and scare that we have? Well, 0.2%, if a large number, let's take a population of 1 million people, right? If you infect 0.2% of the population, that's still quite a number of people that die from the disease, right? So it's the 0.2% number is still an important cause for policy. It's not so that we should ignore the disease, quite the opposite. It's just that we should account for how best to deal with the disease. There are other factors that lead to high risk from the disease. So if this is from the Stockholm study on comorbidities, it turns out that, so if you're over 80 in this Stockholm study, and you have one or greater comorbidities, the comorbidities that play an enormous effect. But still, the single most important risk factor whether you have comorbidities or you don't have comorbidities, is still age. Age is the single most important risk factor. So if you have to adopt a policy that's basically in the heat of war, where it's difficult to make fine distinctions, well, it's very easy to tell how old somebody is. So prioritizing people based on age is the primary thing. So let me stop here, because we made a plan to do 15 minutes, and then I take questions for 5, and then I'll go to the second part of the talk.
So any questions from anyone? Because I have got a question which I'll go to the end, but anyone from the...
Yeah, may I? Hello, this is Dipankar from, I'm trained in economics. So my question would be mostly related to economics and academics. In the Barrington report, the Great Barrington Declaration you made, you very categorically mentioned about the in-person schools and colleges and in-person learning. And in this COVID second wave, do you think that you still believe that in-person learning is the best solution for combating this kind of situation?
May I defer the question to the second half of the talk, because I'm going to discuss about the evidence on pediatric.
Okay, fine.
So I promise I will. That's a very, very important question. In fact, a centrally important question for the right policy. And so let me go through the science on that, the evidence on that, and then we'll discuss it.
Sure.
ডক্টর বোস, ফেসবুকে কিছু কোয়েশ্চেন এসছে, সেগুলো আমি আপনাকে এতে দিয়ে দিয়েছি চ্যাটে।
চ্যাটে বের পাবো। Is there anyone to ask the question of which, where is the chat exactly?
There are
I have some.
I have got question. I've got the chat. Yeah.
Yeah.
There are. I will put the questions, and Professor Bhattacharya, you choose which you would like to answer before we jump into your next session. Is this a pandemic? What are the parameters of defining pandemic? What the death counts of other diseases are not being dealt with in comparison? That's number one. Shall I go?
I think let me address those one at a time. Actually, those are both good questions. I can address them quickly. So this is a pandemic. There's no question it's a pandemic. It's a pandemic that poses an enormous risk for the older population. For the younger population, it does not pose an enormous risk, out of line with other risks that younger populations face. So let me answer the second question relative to other diseases. Tuberculosis kills millions of people a year. And the number of people that die from tuberculosis will continue into the future, indefinite future, until there's a better way to manage the disease. The treatment, in many ways, and I'll talk about this in the third part of the talk, in many ways, a way that we've managed this disease has made the management of many other diseases worse. Tuberculosis is one, but HIV treatment, malaria control, a whole range, polio, vaccination rates for children, nutrition, many other priorities in public health have been put aside to address this disease. And I think on net will lead to more deaths than the lives saved from the lockdowns. But I'll develop that evidence in the third part of the talk.
And coming back to the third question, which I have got, I'll continue with the second part. That is, please tell something about the RT-PCR to detect SARS-CoV-2. How far that is applicable. This brings us to another point which I want to add to the story is, should we be doing this test, because there is chances of transmission of the infection of asymptomatic people. Should we be doing this test? How far is this policy of doing tests for asymptomatic cases justified?
I believe that the testing of asymptomatic population serves almost no purpose, because the problem is that the disease is incredibly infectious, and you're very likely to miss large numbers of them. The only purpose served by testing asymptomatic people is to slow the disease spread. But I think it's a very ineffective way to try to slow the disease spread. It's like putting your finger in a dam that's breaking, and hoping that it stops the dam from washing over you. So I don't think that that's a very effective strategy. We've seen it fail all around the world. It's failed in India, it's failed in the United States, it's failed in Europe, it's failed in South America. It is not a policy that is designed to address this epidemic effectively. On the other hand, the focus protection idea, which I'll show you some evidence, has actually mitigated some of the harm from this disease without causing much of the lockdown harms that I'll show you and discuss in a minute.
Yeah, those were the three questions. And that brings us to the second part of this stringent lockdown versus this force protection, which is very important in this case.
Okay, so
especially to India, in Indian situation.
Yeah, let me address the evidence on lockdown harms. So that's the second part of my talk, and in fact, it's the second basis for the Great Barrington Declaration. So lockdowns are an absolutely extraordinary attempt to address this epidemic. It violates many of the pre-pandemic plans that had been made regarding how to deal with an epidemic of this sort. The pre-pandemic plans, both by the World Health Organization and many other public health organizations, had emphasized not disrupting normal society as to the extent possible and protecting the vulnerable as the extent possible. The Great Barrington Declaration, which is basically those two ideas, is a call to return to that old pandemic plan. Now so I've already described the age gradient, so we know who's vulnerable. Now let me describe the harms of the lockdown. This is the economic, basically. Now in the early days, people had mentioned this as a trade-off between economics and lives. If we only lock down, okay, we'll harm our economy, but we'll save people. What I'm going to argue is that this is a false dichotomy, that in fact, the lockdowns themselves kill people directly. And the only question in my mind is how many more people have the lockdowns killed? Is it 2, 10, 100 times more people than the number of lives saved by them? So first, I'm going to just run through some reports. I'm going to emphasize things that were known in the early days of the epidemic because I think huge mistakes were made then. But the evidence has just grown to since then. In April of 2020, the UN put a report out that argued that worldwide there would be 130 million people who would be put at risk of starvation as a consequence of the economic dislocation caused by the lockdowns. This was 130 million people. 3 million people have died to date, or something like that, worldwide from COVID. How many of the lockdowns saved? I mean, there's no. I argue that the first order answer is close to zero, but I'll show that evidence in a bit. The prophecy that the UN made in April of 2020 has come true. So published in Science, there was an article published in Science in February of 2021, looking at 9 developing countries, tens of thousands of people, very, very large scale survey. And here's the main conclusion. Household coping strategies and government assistance were insufficient to sustain pre-crisis living standards, resulting in widespread food insecurity, which is another word essentially for hunger, and dire economic conditions even 3 months into the crisis. So the first 3 months of the epidemic from the lockdowns had put hundreds of millions of people in developing countries into starvation and poverty. So this is the economic harm. The economic harm is not a benign thing. You're not trading lives versus money. What you're trading is lives versus lives. Well, what about direct medical harms? Well, you have that too. The World Health Organization, again, and UNICEF put out a report that 80 million children, this is from May of 2020, were at risk of diseases such as diphtheria, measles, and polio. Vaccination programs that were disrupted as a consequence of the lockdowns. So worldwide, again, tens of millions of children have not been vaccinated against these incredibly deadly diseases that are incredibly deadly to them. Polio, in particular, is galling because we were worldwide very close to eradicating it. There's the places where polio exists are like in Pakistan and just a few other places. The cessation of the polio vaccination programs in these places will lead to has already led to a resurgence in polio. But these diseases are not trivial for children. There's a reason why these vaccinations are critically important for the health of children, and we've disrupted them. A report put out in March of this year, again by the UN, said that 228,000 children were killed by nutritional deprivation, and by missed medical treatments, the vaccinations being one of them. 228,000 children killed in South Asia alone, and that doesn't count the rest of the world where poor people live. Lockdowns are a luxury of the rich. The lockdowns are a luxury of the rich. The lockdowns protect the rich and the middle class and damage the poor. When the lockdowns were implemented in India in the early days of the epidemic last year, 10 million migrant workers were forced to essentially wander their way back home to their villages, and thousands died in transit, and countless more were harmed. The lockdowns are not a policy that protects the poor. The poor cannot afford to lock down. In the United States, a rich country, there were also lockdown arms, absolutely enormous ones. So on the left is cancer diagnoses before and after the epidemic. The blue line is the baseline level of cancer screening, and the lines to the right are the number of newly identified cancers in the early months, just 2 months of the first 2 months of the epidemic. There was an enormous decrease in the number of identified breast cancers in the United States because people were so scared of COVID that they were more scared of COVID than cancer. That the same was true for colorectal cancer, lung cancer, but especially breast cancer. In the United States, we will see a very large number of women with late-stage breast cancer that should have been identified this past year that will not be. The same is true for diabetes management, right? Enormous decrease in checking for hemoglobin A1C. We're going to have more diabetes death. We'll have more end-stage renal disease and all the consequences of lockdown, of diabetes. In the United States, 1 in 4 young adults, this is from a CDC survey in June of last year, 1 in 4 young adults seriously considered suicide. The lockdowns are not a human way to live. What is a lockdown? A lockdown is an attempt to divide people, to make people not interact with one another. Well, for young people, this is devastating. The psychological harms are devastating. We're seeing an enormous increase in anxiety and depression in especially younger populations, anywhere where lockdowns have been implemented. And I said that the lockdowns are a luxury of the rich. Let me provide a little bit of evidence on this. California has been an enormously locked down country, the state. We've had something on the order of my children, for instance, have not gone to in-person school in almost a year and a half. Los Angeles County has had a lot of deaths. But it turns out that where you live determines whether you died from COVID. If you lived in an area with less than 10% poverty, you had 1/3 the mortality rate from COVID than if you lived in a poorer area. 393 versus 118. This is age-adjusted per capita death rate from COVID-19. And there are enormous race differences as well. Hispanic populations have faced 3 times the death rate than white, and almost 2.5, 2.7, 2.75, something like that. You can 142 versus 337 in death rate by race. That's LA County. Florida, on the other hand, has not locked down. It followed a focused protection policy, and what you see in Florida is very different. In fact, there's no race difference in per capita mortality from COVID. The lockdowns. Let me put the both up together so you can see them. On the right is not lockdown Florida. On the left is lockdown LA County. The lockdowns are trickle-down epidemiology. They're designed to protect the rich in the hope that they'll protect the poor, but in fact don't protect the poor. Okay, let me stop because I think I'm like a couple of minutes over and take some more questions. And I'll get to the children in a second. Yeah.
Thank you. Thank you very much for giving us that data, for very comparative data with Florida with Los Angeles. That is very clear. In India, unfortunately, I think we are following the lockdown approach, which is very destructive in a way, that we are already facing recession, which is likely to lead us to depression in a couple of months. And actually, we are already in depression. So, and I the same question which you have raised earlier in your Barrington Declaration, that the best way to combat this kind of situation would be to expose those people who are least vulnerable, especially the younger population, and you suggested very categorically that the universities, schools, colleges should be open, the restaurants should be open, the amusement parks and all this should be open, and that we found actually probably most scientific approach in handling this kind of situation. Now, in the second wave of COVID, which we listened to from the media, do you think that what you said in last October still holds? If there is any reason why you should be changing your mind or changing your prescription right at present? Your comments on that, please.
Thank you for that question. That's an excellent question. Let me just say that the key principle for the Great Barrington Declaration isn't to expose anybody to the disease. The key principle is protect the vulnerable. And today, with the vaccines that we have a much better, we have basically a near perfect way to protect the vulnerable. Vaccinate the old. And for the young, the lockdowns are more harmful than the disease. So it's a Pareto improvement. By vaccinating the old, you reduce the harm that they face from the disease, because the disease is absolutely deadly. In October, when we wrote this, before the vaccine was arrived, the argument was it's difficult to protect the vulnerable. That was the counter argument, which is true. You would only have perfect protection of the vulnerable. But with the vaccine, you have the mechanism to perfectly protect the vulnerable if you prioritize the old for the vaccines. In India, my understanding is that I looked at the data. The army was prioritized. Many onyoung people. The data show that in India during the last between January and late April, only 40% of the doses of the vaccine went to people 60 and over. That's a failure of focused protection. Yes. What should have happened in those months was to prioritize. Every single older person in India should have received 100 million doses of the vaccine in India. That's an enormous achievement, actually, to give out 100 million doses of the vaccine. That's on the order of how many doses were given out in the US over that same period. It's a huge technical achievement to do that, but the strategy was wrong. Instead of protecting the old, 100% of those doses should have gone to the old. Instead, 60% of the doses went to people under 60. You need to vaccinate nearly 1,000 children to get to save this, in expectation, the same number of lives as vaccinating a single 80-year-old. Dr. Das.
Yes, Dr. Das. Someone.
You're on mute, Dr. Das.
No, I think, yeah.
Yes,
no.
yes.
Yeah.
Can I ask one question?
Sure.
Dr. Bhattacharya, in Great Barrington Declaration, you have said that as immunity builds in the population, the risk of infection to all, including the vulnerable, falls. We know that all populations will eventually reach herd immunity, which can be assisted by, but not dependent on vaccine. After that, vaccines have been rolled out in a big way. Now my question is, what is the epidemiological impact of vaccines on the SARS-CoV-2 induced infection?
Right. So let me address herd immunity, because that's a very, very important concept in epidemiology and of infectious diseases. So herd immunity is a situation when when an additional person, a new person is infected, they spread the disease to one or fewer people. Essentially, the herd immunity is reached when if I interact with, if I have the infection and I interact with people I normally interact with, on average, I spread a disease to one or fewer. If a very large fraction of the population is already immune, when I interact with them, even if I'm infected, there's no chance of my spreading the disease to them, right? So that's the idea of herd immunity. It's premised on the idea that once you're infected, you become some way protected against the disease.
Yes, that's likely. That's natural.
Yes. In fact, there's an enormous amount of evidence, Dr. Bose, that is exactly what has happened. Almost from the beginning of the epidemic, we've seen this. The reinfection rates are very, very, very low from this disease. And people who are reinfected tend to have milder infections than what the initial time they were infected. The vaccines, to answer your question, Dr. Dawes, which is an excellent question, can be used to help that if they reduce the probability of disease spread. So if I'm vaccinated, I'm much less likely to harbor the infection. I'm much less likely to have a lot of a high viral load and much less likely to infect anybody, even if I happen to be infected, because the viral load will be lower. So the vaccines help with herd immunity. Natural infections also help with herd immunity. Vaccines are the more moral way to achieve herd immunity, because you don't actually have to face the risk of the disease, and especially for the vulnerable population, it's the only moral way, really. If before you had it, it's the most moral way to deal with the disease. The question is prioritization to me. So now herd immunity is not a strategy; it's just a fact. That is the end of this disease, no matter what we do, whether we do lockdown or we do focused protection. Either way, the disease is here to stay. There's no possibility of eradicating the disease. In the history of the earth, we've only eradicated one single disease, human disease, by concerted effort, and that's smallpox. And smallpox has no non-human reservoirs. This disease infects dogs, cats, other mammals. You can actually be reinfected. Now the reinfection will be less. You're much less likely to have the severe outcomes. Now, the fact of reinfection doesn't mean you can't have herd immunity. It just means that the disease is endemic, right? Lots of other diseases are like this. Eventually, the disease will be endemic. In fact, I think we're nearing that in many, many countries. So that's the basic idea. The only question is the strategy to reduce the harm from the disease. It's not to eradicate the disease. The idea of zero COVID has caused enormous harm because it's led to the lockdowns. What is the purpose of the lockdowns? To eradicate the disease? Well, in that case, it's failed in Europe, it's failed in the Americas, it's failed in India, it's failed everywhere it's tried with enormous damage, as I've shown.
And what about the masks? There has been a lot of, there's a study which I'm sure you are aware of it. I can read it to you because I've been briefed with this one. In November 1920, there was an extensive study, Face Masks in COVID Era, a health hypothesis by Baruch Van Schelmoen. And it was published as a medical hypothesis for the use and abuse of face masks. It was hypotheticated the practice of wearing face masks has compromised the safety and efficacy profile. Both medical and non-medical face masks are ineffective to reduce human-to-human transmission and infectivity. Wearing face masks has adverse psychological and physiological effects, and long-term consequences of wearing face masks on health are detrimental. This was the study, and obviously going back to my days in England, when we, in operation theaters, we dropped the face mask, just because obviously it was ventilation was better and all those kinds of things. We rarely used face masks and that was standard practice in UK. Does the same rule apply here?
I think so. There was the U.S. Center for Disease Control director last summer, in an incredible statement, which I still can't understand what he was thinking, said that face masks were more effective than vaccines. There is no evidence to say that's true. In the case of influenza, there's 14 randomized studies in healthcare settings and other settings that suggested that for viruses like influenza, face masks are not particularly effective. Now, I don't think that face masks are completely ineffective. So I think there are situations where in principle, you can use. So for instance, I've argued in favor of using face masks in the context of nursing homes and care homes in the United States. The idea there is that, even if they're a little bit effective, you need to protect the old because the harms from exposing the old is so high to the disease. I also think, I think in hospital settings where people actually know how to use the face masks and effective face masks are used, they can be effective. The idea that face masks protect people themselves from the disease, actually, I think has caused great harm. And the reason is this, is if someone who's older puts the face mask on and thinks, oh, I'm now protected from the disease, and then go do activities that expose them to the disease, I mean, you've caused them harm. You've made them think they're protected when they're not. I think the major problem with face masks has been an overemphasis on their efficacy, and as a consequence, very likely it's not. It's actually harmed people, caused many older people to take more risks than they ought to have. The other thing about face masks is I've noticed is that it's divided people in an enormous way. So if I put we've moralized face masks. If I put the face mask on, I'm a good person. If I don't put it on, I'm a bad person, right? Public health should never divide the population in that way. It's a mistake. You should instead give good tools, good information, and say here's when it's useful, here's when it might not be so useful.
Dr. Bhattacharya,
Yeah.
do you think these vaccines are quite effective in preventing the SARS-CoV-2 infection and stop the chain of transmission?
Yeah.
You sound.
Sorry, you are.
Yes, I think they're quite effective.
Yeah.
I think they're quite effective in stopping the spread of the disease. I think the primary, it depends on the vaccine. I think some vaccines are more effective than others. It also depends on variants. I think some variants make the vaccines less effective in reducing disease transmission. But all of the vaccines protect against severe disease, every single one of them. And so I think that's the key thing. It doesn't matter if it stops transmission. What matters is that it protects the vulnerable. If you use it to protect the vulnerable, it'll protect the vulnerable. And that's what, no matter what, all the evidence suggests from the variants that's true. Dr. Manglik.
Yes, Dr. Manglik.
Yeah, may I make a few comments? First, regarding the lockdown issue, I mean, you had commented that, Dr. Bhattacharya, that the routine vaccinations were affected. I wholly agree with you that last year, when the lockdown started off worldwide in our country also, the initial part, the first 3 months, maybe April, May, and part of June in 2020, the routine vaccines were affected, even both in the public sector and the private sector. But after things have normalized, and as of now, as of May 2021, all routine vaccines are being routinely administered, and parents are being counseled that don't miss out the routine vaccines, number one. Second comment was regarding the amount of vaccines which have already been administered in our country. As of 23rd of May 2021, around 190 million doses of vaccines have been administered to around 150 million people. 40 million have probably got both the doses. So that's the second part. And regarding the efficacy of the vaccine, somebody was asking, I mean, let us be very, very clear. We have got enough data in our own country, despite the fact that whether we like it or not, we are not very good at maintaining records and having good data from our country. Despite the large numbers we have evidence to the effect. And I'll just quote one evidence. In the second wave, which we are facing right now, around 400 medical personnel have succumbed to COVID. And would you believe it? Only about 10 of them were such who had got the vaccine. The rest, 390 odd, did not get the vaccine. That was very, very unfortunate, despite the fact that they being prioritized earlier on to take the vaccine by the government also, but they didn't take it for whatever reason they best know, and they suffered. So the vaccines definitely have saved lives, have reduced serious illnesses. Yes, it may not have reduced the overall incidence of the disease, but yes, that also has come down. But that does not mean that, like some people ask, that will it guarantee I will not have COVID? Nobody guarantees anything in life. That is very true. Thanks for giving me this time, Dr. Bose and Dr. Bhattacharya.
This thing coming from Dr. Manguri's question, it brings me another question: is this mask drive for vaccination and routine sort of use of a vaccine certificate, if you want to board a flight, have you taken a vaccine or something like that, and all those kinds of things. What is your views on that, Professor Bhattacharya?
Okay, so let me get to Dr. Manglik's. First of all, let me thank you for the questions and thank you for the comments. I think I agree with almost everything you said. You're right and in fact, it's a good thing that in India, the vaccination for routine vaccinations has ticked up since the early days of the epidemic, and that's a good thing. But that's not true in many poor countries, unfortunately. Like in Africa, for instance, I think it's still down. It's still quite a crisis. Pakistan, actually, I think the polio vaccines are not been put out. So, I mean, so I think that,
other reasons.
Yes.
For the polio thing, there are other reasons. We won't go into that.
I know about those, but I think this hasn't helped. But I think that so that's good news, but for India, but not good news yet. Full to my satisfaction for the rest of the world. For much of the rest of the world, I entirely agree with you about the 100. I said 100 million. Now it's 120 million. That's a really good news that India has managed to vaccinate such a large number of people in the few months. My criticism of Indian policy is that 60% of those doses went to people under 60. I'm really pleased that the healthcare workers who care for people who are older are also vaccinated. They should be prioritized. But it should be a very large fraction of that should go to the older population, and that unfortunately has not. And I think that's what really needs to happen. And now, Dr. Bose, you ask about vaccine passports. I don't really understand the purpose of them, right? If the purpose is to tell people who are older that this is a safe place to go because everyone else around me is vaccinated, well, if you're vaccinated, you're safe. The vaccine protects you against the disease. They work. These vaccines are incredibly effective, as Dr. Manglik said. Absolutely, amazingly effective. So if you're older or if you feel yourself at high risk, then get a vaccine. What the vaccine passports serve to do is to divide the population. In India, I believe that somewhere on the order of 50% of the population already has had infection, maybe higher. Do you require them to be vaccinated? They're already immune to the disease, or they're protected against reinfection. They don't need that. And yet you say, okay, you have to get the vaccine in order to participate in normal life. I don't think it's reasonable to ask people to do that, especially when they're already protected. I see a whole bunch of questions, but I want to cover the pediatric questions Dr. Day said. And okay, so there's still, all right, I'll take the two questions then, but then you'll have to give me
yeah, sure. Okay, you go on. Later on, if time permits, I'll ask.
Okay, so let me cover the pediatric evidence, because I think it's so important, and I'm really pleased that you asked me that question. Let me find my slide deck. Oh, here it is. Okay, so in the United States and India and very few other countries, there's been a policy of routine closures of schools. I believe the scientific evidence does not support this, and let me discuss some of that evidence. Probably the single most important study is a study that was published in the New England Journal of Medicine in April of last year, I think, or April or May of last year, I forget. April of last year, and it was a study done in Iceland. In Iceland, they have a capacity which the United States doesn't have, where they surveyed almost 15% of their population, I think 12 to 15, somewhere in that order, 15% of their population, with a random sample. And they took nasal swabs from every single person. They sequenced, when they found the virus, and they sequenced the virus with a genetic analysis, so that if the virus mutates all the time, as we've learned from the variants, the genetic analysis is really useful. They match this to a contact tracing study. The genetic analysis allows you to, the problem with contact tracing studies is, if I have the disease and I say I was in contact with you, well, it's hard to say whether you pass the disease to me or I pass the disease to you. You can't tell which direction the disease spread. With the genetic analysis, you can tell, where you have some indication, right? So if I have mutation A and you don't have mutation A, and I have mutation, I don't have mutation B, but you have mutation B, well, it's unlikely we pass the virus to each other. It's probably a third person that passes it to both of us, some other people that pass it to each of us. On the other hand, if we both share mutation A and mutation B, then it's quite possible I pass it to you or you pass it to me. And in some cases, you can tell we share mutation A, you have mutation B, I don't, then I probably pass the virus to you rather than the other way around. You can tell the direction of the spread of the virus based on the pattern of mutations. In Iceland, this research group did this at population scale, an enormously elegant study. The senior author of the study gave an interview later about the study, and he said an absolutely remarkable thing, which is that children don't infect parents. In Iceland, the children did not pass, when they were locked down, children did not pass the disease on to their parents. Many parents pass the disease on to the children, but not the other way around. Children seem to react to this virus immunologically in a different way than adults. That makes them much less likely to spread the disease than the other way around. It's not like the flu. The flu, children pass the disease on to others. Many common colds, adenovirus, children pass the disease on. But this virus, for whatever reason, children do not pass the disease on at very high rates. They're not very efficient spreaders. It can happen. It's not zero probability, but it's much less likely. On the basis of this kind of evidence, worldwide, schools stayed open. But with enormous amount of attention paid to whether or not that this was causing disease spread. In the Netherlands, for instance, there was a study published in August of last year. Worldwide, few children reported COVID-19. Children, by the way, are much more likely to have asymptomatic disease than adults. And as we showed you, much less likely to die. And let me show you the main finding. The novel coronavirus is spread mainly between adults and from adult family members to children. Spread among children or from children to adults is less common. In general, the younger the children, the less significant the role they play in spreading the virus. This is from the main public health agency in the Netherlands. In France, at Institut Pasteur, they did a study of how common disease is spread in the community from open schools, and they found that in primary schools, no significant transmission from children or from students to teachers. In Ireland, no evidence of secondary transmission of COVID-19 from children attending schools. The schools don't drive the spread of the disease. The schools reflect the community spread of the disease, but they don't drive it. If the disease is spreading in the community, the schools will get cases. But the schools aren't the cause of the disease spread. It's the other way around. Germany, same finding, right? In contrast to other epidemic viral respiratory infections, the primary source of infection of SARS-CoV-2 appears not to be other children. Most children in the study were infected by their parents. South Korea, the UK, people suppose little risk of spreading disease in the single largest study that was done. Let me just stop this section with one other point about from Sweden. Sweden kept its schools open for children under 15 through the entire epidemic. No masks, no social distancing. And very few children, I think on the order of on a handful of children actually got the disease and with enough to die from it. Less than the flu. And here's the main important thing. Teachers were infected and had severe outcomes from the disease at lower rates than the population at large. It's safer for teachers to be in school than they are to be wandering around the community, because they're around little beings that don't spread the disease to them. And now I haven't even talked about the harms of closing schools. In-person instruction is an absolutely vitally important input into the well-being of children that last their entire lives. The single best investment we can make is in children, is by giving them an education. By essentially holding back education for a year, that we have created a generation of children who will live their lives poorer and in worse health, and will live shorter lives as a consequence. We've built in the United States and to some extent in India, our strategy to address this epidemic on the backs of children, harming them with, unfortunately, I think, very little benefit to show regarding infection control.
Professor Bhattacharya, sorry, anyone wants to say anything? Because
Professor Bhattacharya, is this true also for the young people? I mean, those who are in the age between, say, 16 to 24 or 23. Is it also true for those section of people? No. Because they constitute the college students, university students and all.
Yeah, so this is true for younger than 16, not true for older than 16. I think it's it's not like all of a sudden people start it's gradation. But I'd say around 16, 17, 18 people that the facts I showed you don't hold about transmissibility. Under 15, it's very unlikely to transmit, much less likely to transmit. The logic for 16 to 24-year-olds and so on is a different logic. You're harming them. They're very unlikely from the lockdown. The lockdown harms them in severe ways, and they don't benefit at all because they themselves have very low risk of severe outcomes from COVID. Essentially, we're asking them to adopt strategies that harm them to protect the old. But you can protect the old without that. Why harm them when we can adopt other strategies to protect the old?
So on that logic, you suggest that the colleges and universities should also be open, right?
Correct. And I personally would be, so let me just to give you a sense, I'm 52 years old. My mortality risk from COVID, if I were to get infected or before I was vaccinated, is 0.2%. I would happily, my job is to teach people that age. I would happily take that 0.2% risk in order to be more effective teacher. Dr. Chakrabarti.
Yes, what I want to make a point that a take-home message from your discussion so far is that lockdowns are ineffective for the whole population, and lockdowns are rather a luxury of the rich. Can we take it?
Yes, absolutely. Yes, I think that's fair. I think it's a form of trickle-down epidemiology, right? It's an attempt to try to protect the entire population by protecting the rich. And actually, unfortunately, from what we've seen from the Indian experience, it ends up not protecting the middle class and the rich. I think the second wave in India is a spreading of the disease to the middle class and the rich populations. The first wave. So I'll give you an example of this. In July of last year, there was a study done in Mumbai by a friend of mine, Anup Malani from the University of Chicago. And what he found was that in the Dharavi slums and the other slums of Mumbai, the seroprevalence was something on the order of 50–60% of the population of the slums had been infected. Whereas the population at large in Mumbai was only 20%. I think that's reversed in this wave.
Thank you.
Professor Bhattacharya, there are a few questions which have been put in. I put it in 3 sets. I will go one set by the next to understand. Someone says that new scientists on 15th May 2021 reported that there are signs that it is better of spreading among vaccinated people. Number one. With that, he asked the question whether it's COVID-19 is a common flu or not, and is there any proof that the vaccinated people are not spreading the disease? What about Sechilis?
Yeah, so I think we addressed that question earlier. I believe that for most disease variants, that the vaccines, the mRNA vaccine certainly, and also I think also the AstraZeneca vaccine that's in common use in India, both are effective against slowing disease spread. There are some variants, I think the South African variant is one, where the disease, where the vaccines are less effective at stopping disease spread, but still very effective at protecting against severe outcomes, hospitalization and deaths.
Sure. Anyone want to ask questions? Yeah. Someone I interrupted? If not, then I'll continue with some other questions people have put forward. Is the vaccination of elder population pushes, what can we say about the virus adaptability of the younger ones? Does the vaccination force mutation designed to affect the younger ones? That brings us to another big question of mutation and spread in this second wave or third wave, whatever you name it, in whichever form it's coming. The mutation and how, when it will reach that endemic stage, when we have the curve and then it falls down, how many cycles we have to go through that?
Okay, so let me. Can you all stay a little longer? I actually have a whole section on that. If you want to answer that.
We are there to listen to you by all means.
So, but for, regarding the question about variants and what ends up happening with the variants, to me the key question is: do the variants change the age gradient of mortality risk? Because if it does, then you need a very different kind of focus protection policy. To date, I have seen no evidence that it does, that the variants have any effect on the age gradient of who's at risk. So, and now related to that, use your question: does vaccination induce more mutation and more selection of dangerous variants? I think the answer is that we don't know the answer. Nobody knows the answer to that question. This virus, just like every virus has been mutating continuously since it was first sort of spread through human populations, probably even before. And it's not surprising that it's become more adaptable. At the same time, most mutations that it acquires tend to make it less deleterious, not more. There's a phenomenon of like the people who are most vulnerable to it died first from it, and the people so to some extent, I'm not terribly worried about the variants. In part because the only thing that matters is the age gradient. And I don't see there's been no evidence at all that suggests the age gradient in the risk from the variants has changed. The other thing that to remember is that the vaccines, we produce them, I mean, in an absolutely remarkable sort of time period, within 9 months. And the mechanisms for the vaccines, this mRNA platform, can be adapted very rapidly to other to variants that actually change the profiles. So, I mean, I think the worry about the variant should not drive public policy. We can't control evolution. We shouldn't pretend we can. What we can do is identify the vulnerable and protect them.
Before you go to the next part of the presentation, which we definitely have got the time to hear, one more question, if you can answer, then this finishes the lot, and then we'll hear what you have got to say and what we hear. This is that, are this vaccination, this drive, resulting in immune escape? That was another question.
I'm sorry, is the vaccination drive resulting in what?
Going for resulting in immune escape.
Immune escape. I don't think so. But again, I don't worry about that. We don't need to worry so much about immune escape. We can't control it. I mean, I've been seeing arguments in the literature that the vaccines that actually reduce the risk of dangerous variants, and I've seen arguments the other way. I don't think the scientific evidence is settled one way or the other on that. And we can monitor it, but the key thing is to monitor is do the variants change the age gradient? Because the focus protection policy just depends on the age gradient and risk. If you have that plus lockdown harms, that's the entire scientific basis for focus protection. I've seen no evidence at all that the variants or any indication that the variants would do that, would change the age gradient. There was someone in chat had a question.
I think Dr. Mukherjee, Dr. Kirti Mukherjee has got a question.
Actually, it was more like a comment. So my UK experience is we have now got 70% of the adult population vaccinated. The first dose has been given to 70% of the population, and 40% have got the second dose, so fully vaccinated. So this started in December, mid-December, and the cases have steadily fallen from January. And the way the vaccinations were given out were, first of all, it was age criteria, so 80 plus, then 75 plus, then 70 plus plus all the vulnerable adults, whoever has underlying immunocompromised conditions or whatever. And that seems to have worked. So we are now down to 35 years and above. And it seems that it has worked. And the lockdown wasn't as strict as last year. And things are open. Of course, the universities are closed, but the schools are open for the last 10 weeks. And it doesn't seem to have, the infection doesn't seem to have gone up. So I think lockdown has its collateral damage, sure, but vaccination does seem to have worked. And I think vaccination hesitancy is far more prevalent in India than here, because 90% of those who were offered vaccination have taken vaccination, and that seems to have worked, in my opinion.
Dr. Mukherjee, I completely agree with you. I mean, the vaccine rollout in the UK is an enormous success. I don't understand why the UK still has any lockdown policies whatsoever, given its success. The old are protected. In the US, the same thing, right? The states that vaccinated earlier, the old population have had less deaths. I'll show you some evidence on that from Florida.
Our lockdown are supposed to be shifted. They will be lifted by 21st of June, provided the Indian variant doesn't, make a huge impact here. So that's why they are just treading carefully. But the schools are open, and then the indoor mixing and the restaurants, and now they're all open.
That's good to hear. Although I am really concerned about this. There's no evidence that the Indian variant is any different than any other variant in terms of the age gradient of mortality, which is the only fact that matters. And I think what I'm afraid in the UK is that they've used this idea of an Indian variant essentially to close borders in this sort of xenophobic way. I don't really understand. That part of the policy doesn't make sense to me.
Well, yesterday they have announced that the Pfizer vaccine protects against Indian variant by 88%, and the AstraZeneca is 66%. So 88% is still pretty good.
But the thing is, Dr. Mukherjee, is that it's protects against what? Against mild infection. Who cares? What matters is severe disease and death. It protects against severe disease and death, like 90+%, both of them, in the Indian variant or not, right? I don't really. I mean, I think a lot of this is scaremongering. I think part of it is scaremongering. Part of it is not understanding what the right strategy is. The strategy isn't to stop the disease from spreading. You cannot do that. It's not possible, as we've seen from failed policy after failed policy. What matters is protection of the vulnerable. And the UK has done that.
I think UK has done that part very well. They first protected the vulnerable first. And what they did is they totally stopped 2 million people from coming out at all from home. They just did not let them get exposed. But people who were exposed died in big numbers.
Well, the older people who were exposed died.
Yeah.
So
and
thank you.
The nursing home people, maximum nursing home people, people who are in nursing home died. A lot of them. Yes.
Same thing in the United States. 40% of the deaths are in nursing homes. 80% of the deaths are 65 and up in the United States. It's heartbreaking. And in India too. Same thing in India. It's the older population that's died in India.
Professor Bhattacharya, you were going to give another part of the presentation. We do have the time.
Do you? Okay, good. Because I I promised 3 parts. I actually have 5 parts. Let me just show you. Let me do the next 2 parts, and then we'll end with questions. How about that? All right. So let me show you a case study in whether lockdowns were successful from the United States. So I picked California because I live in California, and I picked Florida because it's the one of the few. So the governor of Florida actually took my advice. I talked with him. We had a whole series of roundtables, policy roundtables, and he followed the Great Barrington Declaration advice. It's the one state where I think it's sort of clean, most clean in following it. So this is data from the Financial Times tracker for COVID-19 cases in California and Florida, dating back to the beginning of the epidemic. Both California and Florida closed the states as a lockdown in the early days of the epidemic. You can see that they tracked each other in cases for months afterwards, with almost no difference in the number of cases for the first few months. Now, Florida is in blue, California is in red. In the summer of last year, the number of cases in Florida started to rise. California shut down churches, businesses. The lockdown in Florida was actually much less stringent. It was, for instance, they kept churches open, right? They kept they said that churches will remain open, right? So, but he shut down businesses. California and Florida both reopened with some restrictions in May. My children didn't go to school. My children have not been in school in person in a year and a half in California. In Florida, the schools started to reopen. In Disney World, which is located in Florida, was opened in July 11th of last year. Disneyland, which is located in Southern California, is closed. Right, so Florida is a lockdown, has essentially avoided the lockdowns. In September, California opened to some extent, but still kept schools closed. In late September, Florida fully reopened. All remaining restrictions were gone. Now, during this time period, Florida had seen a fair number of cases. The blue curve is higher than the red curve. And there was a lot of, when Florida reopened, Dr. Fauci in the United States lamented that fact. He said that Florida was putting itself at great risk. And California had these tiered restrictions, which essentially kept the state closed. Schools closed, businesses closed, churches closed. And in early November and through December, there was an enormous rise in cases in California, despite the tiered restrictions. And in early December, California implemented a severe lockdown, again, another shelter-in-place order similar to the early days of the epidemic. At the same time in December, the Florida governor was saying, December 15th, that restaurants will remain open, right? Finally, the number of cases in California actually exceeded Florida's by the end of January, and California lifted its shelter-in-place order, re-implementing the tiered restrictions with schools still closed. Florida has had open schools this entire year since September. There were these cases of these mass. So this is in the United States. If you live in a state like Florida, it's actually masks are many places optional. To someone living in California, it's a shock because almost 99% of California, 90+% of Californians wear masks all the time, still, even after they're vaccinated. So this video was shown in national TV in March, and it absolutely shocked people in California to see people in Florida shopping without masks. But here you can see the county where the video was filmed. After it was filmed in February, there was a huge decline in cases. There was a Super Bowl, which is a major sporting event that was held in Florida in February of this year. You can see people walking around in close contact with no masks. That's in Hillsborough County, Florida. There was a decline in cases after that event. If you look at the age-adjusted mortality in Florida versus California through March 2021, I think, and that's true still through April, Florida it's one of the oldest populations in the country, so you need to adjust for that fact. But once you adjust for that fact, you have this age-adjusted mortality rate. Florida has 50% lower death rate from COVID than California. 50% lower death rate from COVID than California, despite not locking down. The lockdown, and I showed you earlier evidence that Florida has more equal outcomes from COVID than California. Florida has had better COVID outcomes than California, more equal COVID outcomes than California, and it has not locked down, so it's avoided many of the lockdown harms. Right, I showed you this already. Now I did a study that was published in the European Journal of Clinical Investigation comparing the Swedish and South Korean experience versus other more lockdown states like Spain from the early days of the epidemic. The same conclusion you find. While small benefits can't be excluded, you can't find significant benefits from mandatory business closures and from shelter-in-place orders. Similar reductions in case growth may be achievable with less restrictive interventions. The lockdowns, I think, are a failure in the imagination. We fail to understand what these lockdowns actually can and cannot achieve. And they actually have not slowed the spread. Now, the question is why? Well, it's because most people can't comply with them. They're inhuman. So if you're rich in the United States, you can afford to set shelter in place. You can have people deliver groceries to your house. You can do all kinds of things to make sure that you yourself are not exposed. But what about the people that are serving you? Right, they're exposed. The lockdowns do not act. They're not like, we're not like rats in cages that can be kept apart from each other indefinitely. Right, we're an integrated society with people by nature having to interact with each other. If it were possible to really keep us apart for 2 months, every single human, mother from child, parent from grandparent, for two months, maybe you could use the lockdown to stop the spread, but that's not actually humanly possible. Human societies aren't built to allow that kind of lockdown from happening. In Florida, and versus California, one measure of the success or failure is not COVID deaths, but excess mortality. Excess mortality means how much mortality was there for all causes relative to the previous years, the past few years' experience. It turns out that for 25 to 44-year-olds who don't die from COVID at very high rates, excess mortality in California, especially during the severe lockdowns of the winter, have led to very, very sharp increases in excess mortality, whereas that's not true in Florida. The lockdowns have harmed the young, including killing the young at much higher rates than they otherwise would have died in California, and Florida has largely avoided that. Yes. Yeah, I think my verdict is that these lockdowns were a costly failure. I have a bit about herd immunity, which I can cover right now, but this might be a good time to stop and take a couple more questions if you all will want to stay with me.
I think you can speak few more minutes. I think we are
okay.
Not that eager to leave you right now.
Okay.
If you can spare time, that is.
I absolutely can. I told you. I mean, I've been looking forward to this talk for a while now to talk to you all.
Thank you.
Okay, so let me tell you about the end of the epidemic. And I've discussed this already to some extent. So the end of the epidemic is herd immunity. Now, this has been used as a propaganda tool to say, look, we should infect the entire population. I hope one thing I conveyed to you is that I am not in favor of infecting the entire population. That's false. We have an absolute moral obligation to protect the people that are vulnerable, and we know who they are. They're the older population. Herd immunity is a basic biological phenomenon that, as I explained earlier, that arises when the proportion of the population is immune, and when that population is larger, random interactions between individuals, an infected individual and someone randomly chosen in the population, is less likely to result in a transmission because the immune person is unlikely to be infected. That's just a basic biological fact. It's like gravity, right? The gravity, whether you believe in it or not, when you design a plane, you have to take into account that there's gravity. That is the same is true in the context of managing this disease. It's a biological fact that herd immunity will eventually end this disease. For instance, Zika, why is Zika not a big problem now? Because of herd immunity. There are 4 other circulating human coronaviruses in common circulation. It also has herd immunity as its main, as the mechanism of control. This is not a exotic concept where you're trying to infect people. Quite the opposite. What this is a basic biological fact about how diseases get controlled. Now, vaccines enormously help herd immunity because it allows people to become immune without actually having to be infected. But even before vaccines were invented, herd immunity controlled diseases in the population. If they didn't, there would be no human civilization at all. Everyone would be dead from the diseases that spread to them. And this disease is no different. When you're infected, you develop mechanisms, antibodies only being one of them, immune mechanisms that protect you against reinfection, that automatically means that there will be herd immunity if the disease spreads wide enough. There's some math around what the herd immunity threshold is. The herd immunity threshold, all it means is the level of the population, the fraction of the population that's infected, such that when an additional person is infected and they randomly mix with someone in the population, on average, they spread the disease to one additional person or fewer. That's the definition of herd immunity threshold. Very often you'll see this math that says, look, it's 1 minus 1 divided by R0 being the number of people that the first person infected. Subsequently, so the first person infected randomly mixed in the population at large with nobody immune. If maybe they spread the disease to 3 other people, right? Maybe 4. If we knew that number, we could, with this math, calculate the herd immunity threshold. This is a very simplistic number, by the way. You wouldn't normally use this in actual settings. This is what you teach your undergraduates, just to give them a sense of the dynamics at play. So this is not a serious number, but like people say, what's the herd immunity threshold is 75% or 80% or whatnot. The answer is nobody knows that threshold, and it very likely changes over time. So for instance, the real world complications around this include things like seasonality, right? This disease in particular is very obviously seasonal. When a country that's closer to the equator, the seasonality would be less evident. Countries far away from the equator, you get regions far away from the equator, you get more evidence of clearly visible seasonality. The season, for instance, in much of the northern United States was late fall and early winter. That's why you saw this massive wave. In the southern parts of the United States, where it's warmer, it tends to be last year it was in the summer. So you're likely to see some rise in cases in the United States in the summer. Another complicating factor that's important is immunity loss. Immunity after COVID infection seems to be very long lasting, at least a year. And if it's like the other coronaviruses, it's in a sense a lifetime. It's not that you can't get infected a second time with a human coronavirus, but the second time you get infected will be much less severe. The other coronaviruses are called common cold viruses because you were infected with them when you were young and didn't hurt you very much. And then you keep getting reinfected with them maybe every other year, every 2 years, every 3 or 4 years. But it's just a cold. It doesn't really, you're sick for a couple of days and you feel better. So there's immunity loss to this, which is true, but and that's an important real world complication. Another real world complication is overshooting. So when you have a newly introduced virus in a population, the herd immunity threshold is actually not that meaningful. What happens is when you hit the herd immunity threshold, additional persons infected, well, there's still lots of people actively infected. You can actually overshoot in the herd immunity threshold, and so you get a larger fraction of the population infected than you would normally get if you were in this herd immunity equilibrium. And then finally, this idea of heterogeneous mixing, right? The idea of herd immunity threshold envisions someone randomly chosen from the population. You take an infected person, you interact with a randomly chosen person. But in fact, there isn't random mixing in populations. So in India, we already talked about, and actually in the United States, it's true as well. Poor populations tend to mix with each other, richer populations tend to mix with each other, and there's less random interactions between rich and poor. And that also changes the dynamics. So it's a very complicated thing. It's not as simple, X% of the population is immune and therefore the disease is gone. You can use these ideas to try to think about the disease dynamics, right? So here in black is a population. This is theoretical, not brought from real world populations, but I think it's very helpful to think through this theory. In black is the herd immunity threshold that changes over time because of seasonality, right? In the summer, the herd immunity threshold is very, very low. A small fraction of the population is immune, stops the disease from spreading. In the winter, the herd immunity threshold is very, very high. You need a very high fraction of the population immune in order to stop the disease from spreading. Now imagine the green, the disease is introduced into a population. overshoots the herd immunity threshold, and then the proportion of immune declines over time. Well, what you see there is a one big wave, and then no more waves for the next 2 or 3 years. I don't believe actually any country is like this. I believe that there's be some country. On the other hand, take the blue. I think blue is a good example of this is New York City. New York City had an enormous wave of cases when the disease was first introduced. It was introduced in March or April, which is the declining part of the seasonality of it. It overshot, and then the proportion of immune dropped. And this second wave in New York City is just the herd immunity threshold coming back up. And so you get this small second wave versus the enormous first wave in New York City for the blue. Someplace like Florida, essentially it's the seasonality of it is that it was introduced in the summer, or the sort of started spread in the summer. You get again an overshooting, and then you get these little tiny mini waves that float around the herd immunity threshold. And again, you'll see the seasons. This disease will be a seasonal disease forever. Now, what about a place like New Zealand or Australia? New Zealand and Australia, what happened there is that they were very clever. They located themselves in the southern hemisphere. The disease was introduced essentially in their summer, when the herd immunity threshold was low. Their island nations with essentially very few places where international travelers would come in, and there the lockdown actually did reduce the disease to zero because they had very few cases to begin with. Remember at the start of the talk, I said that in Santa Clara County, there are 50,000 cases, 50,000 infections, only 1,000 had been identified. Well, New Zealand and Australia were very lucky in the sense that they actually had very few infections to start with. And because of that, the lockdown worked. The problem that they find themselves in is now they can't open their nation up. They are isolated from the rest of the world for fear of much of their population, unvaccinated, is at risk from the disease. When they open up their borders, will face the disease spreading in their populations. For them, what they have to do is they have to protect the vulnerable. They have to vaccinate the old before they open up. There's an irony, which is that because they had zero COVID from their lockdowns, their very, very early lockdowns, they could not have developed the vaccines there. In order to develop the vaccines and test them, you actually have to have cases. So ironically, they're relying on the rest of the world to protect their population. The suffering that India, the United States, Europe, the Americas have faced, they're benefiting from that, in a sense. Okay, so what is the end of the epidemic? There's no chance the world will eradicate COVID-19. It's too widespread. There's animal reservoirs, and we have no policy tool, no lockdown, or technology that will eliminate the virus. The endpoint of the epidemic is herd immunity. And so the only question then is not, you shouldn't think about herd immunity as a strategy. It's like gravity. When you land a plane, you have to take into account gravity. The strategy for landing the plane is how you land the plane safely. The same question is here. What is the right policy that minimizes both COVID-related morbidity and mortality and excess burden, the lockdown harms? The sum of those two until the end state is reached. That's the only relevant question. That's the right economic way to think about this. That's the basis for the Great Barrington Declaration, by the way. It's not to say we should achieve herd immunity. That's nonsense. That's what's going to happen no matter what we do. The only question is, can we protect the vulnerable until we get there? The science is not even that complicated. I mean, I don't actually fully understand. I don't understand why this is a controversial strategy. The right strategy is protect the vulnerable. We know who the vulnerable are from the science of it. Let me put it another way. There are a million interesting scientific questions regarding this with a huge amount of uncertainty. You all have asked me some of them, like how well do the vaccines protect against the variants? Do the vaccines induce more evolutionary variation? A whole range of interesting scientific questions. How long does immunity last? All of those questions, if you adopt a lockdown policy, you have to have a particular answer to all of those questions. How widespread is the disease in the population for the lockdowns to be effective, correct strategy? On the other hand, and so any change in those scientific parameters in the lockdown becomes ineffective. On the other hand, this focused protection idea, it only depends on two facts. It depends on this age gradient and mortality, which is absolutely true, seen everywhere, and there's no dispute, and the fact that the lockdowns themselves cause enormous collateral harm. If you put those two together, that's the intellectual basis for the Great Barrington Declaration. Protect the vulnerable, let everyone else live their lives. And in Florida, actually, they follow this policy. By the end of January of last year, every single nursing home in Florida, every single patient in every single nursing home in Florida had received the vaccine. If you do this strategy, you decouple deaths from cases. Cases can go up, cases will go up, but the population that's really would be harmed from the cases going up is protected because you use the vaccines differentially to protect them.
So that brings us to a vital question of a symbiosis between the politicians, the media, and medical scientific opinion. That is where the biggest problem I see is they are, I don't know what the politicians think or the media thinks, but the scientific facts, have they taken into the scientific facts into consideration when they make their policy, be it any country? I'm not talking of any particular country.
Yeah, I completely agree with you. I think that's been so let's just take them one at a time, right? So the politicians, and I'm not going to pick any particular politician out because I think almost every politician has faced this. They had no idea what to do. And what they're solving a particular problem. They need to look like they're doing something, or else they don't look like they care about the disease. Lockdowns are a very, very easy thing to latch onto and say, look, here's proof I'm doing something. I care about the disease. The scientists, well, if you get scientists in a room, you're going to get 1,000 opinions about 5,000 things, right? Each of them vociferously arguing one way or the other in favor of the thing. It's confusing to politicians listening to them. And you have a group of scientists who are very strongly in favor of lockdowns because they don't understand the economics of it. They may understand the disease dynamics, or the virology, or they may understand the math of herd immunity, but they don't understand the harms of the lockdown. What you don't have is a set of scientists who have this sort of broad set of perspectives. Or to put it another way, maybe there aren't any such scientists. What you need is a very, very broad set of scientists with, as a whole, conveying a broad set of perspectives. I think in the early days of the epidemic, most scientists commenting on it, and these were like epidemiologists and virologists, they had no idea that the lockdowns could cause any harms whatsoever. So I think that the scientific voices heard by the politicians was of a very narrow set of scientists. And the media, they just amplified it. They amplified the narrow set of scientists. They amplified the fear. And many governments actually adopted fear as a strategy. That certainly happened in the UK, for instance, in order to get the population to comply with the lockdowns. So I think this is a very toxic brew, and it's going to be very difficult to undo. I think it corrupts science. It's caused countless lives to be harmed. Dr. Das, I saw your question. I'll get to you in a second. And I think it's and for the media itself, I think they discredited themselves because they don't understand the science either. The nice thing about, the amazing thing about this Great Barrington Declaration is actually just the old pre-pandemic plan. There's nothing original in it. Is that it doesn't depend on all this uncertainty. You can have all the questions answered, of the scientific questions answered many different ways, and still the right strategy is focused protection. All that matters is the gradient of risk of severe disease by age and the fact of lockdown harms. Dr. Das.
Will it be right to say that herd immunity can be reached independent of vaccine?
Yes, it can be.
Now, my second question is, what is the scientific rationale of giving vaccine or continuing vaccination, mass vaccination drive in the presence of an epidemic? How can you see it from epidemiological point of view?
Yeah, so the mass vaccination drives, in my view, there's two purposes you can think of them. One is to stop the disease from spreading, essentially to try to get to zero COVID. The other is to protect the vulnerable. I think that the vaccinations are a tool for focused protection. That's the right way to use the vaccines. Because I would rather. I'm sorry, Dr. Das, let me just finish and I'll let you go. So
if it is a tool of focused precaution or focused action, so should it be applied in a focused way?
Yes.
Or should it be applied en masse in the presence of an epidemic? Because you don't know how many people are infected, naturally infected. Even if a person is naturally infected, would you go for vaccination for him? Is it?
Yeah, I agree with that.
Logical?
I think that's a really good question, Dr. Das, and that's really right. So if someone has natural infection, the vaccine does nothing. You've wasted the vaccine dose. And it might even be harmful because there's some side effects in the vaccines. On the other hand, if you use it as a tool of focused protection, you identify the vulnerable and use it on that population, you've defanged the disease. You've turned the disease into a cold, because the population that's most at risk is no longer at risk because you've vaccinated them. And the rest of the population, it's much less likely to harm them, just by dint of the fact they're all younger.
Yeah, from what you have just now said, can I then conclude that before vaccination, the policy should be the person to whom you are vaccinating should be tested at least before a week or maybe a day or two, so that we know for sure that the person is not infected with the disease, and we don't misuse the vaccine or put this person to different types of side effects of the vaccine. Do you think so? And in India, we are not following that.
Yeah, I think so, and I think no country is following that, Dr. Day. It's a very strange thing. It's kind of a form of immunity denial, as if somehow if you're naturally infected, you don't get immune or you don't get some protection.
Exactly.
It's anti-scientific. I don't really understand, and it's also, given that the vaccines are so scarce, 100 million doses, we need to treat them as valuable commodities.
Absolutely.
And if you've already been infected, you're not getting very much benefit from the vaccine. Right, so I think that it's an economically naive way to deploy the vaccine. There's a question in the chat as a direct message. I won't say who's asked me this, but let me just address this because I think it's important. The question is regarding the Seychelles, the islands of Seychelles, which actually did vaccinate a large fraction of its population, and yet is seeing an increase in cases. I think the problem there is that the vaccines that were used were not particularly effective vaccines. They were neither the adenovirus vaccines nor the mRNA vaccines. There, what you're seeing is a breakout in infections. Now, I don't think actually you're seeing a very large number of severe outcomes in the Seychelles. What you're seeing is that the vaccines that were used in the Seychelles didn't protect against transmission, which, as I said, is not the key question. The key question is, are you protecting the vulnerable with the vaccines? I think so I think if you think about the vaccines, you're going to, some places you're going to see cases rising despite increases in vaccination. Actually, India is a good example of this, right? There, you see some cases happening even in populations that were previously infected to some extent. Mostly not reinfections, but some. The transmission of the disease will continue into the indefinite future because you have this immune decrease over time. It's like the other coronaviruses. They circulate in the population, and they will forever, because we can't get rid of them. We just have to learn to live with them. And fortunately, our bodies remember the previous infection. Our bodies remember the vaccination, so that when we're infected a second time, 3-5 years from now, that second infection won't be a severe infection. It'll be a cold. right? That is the end point of this disease. It's an endemic disease that stays in the population.
There was a question from the comment section, actually. What do you think about Professor Luke Sittinger's famous virologist opinion about vaccinated person is responsible for spreading new variant?
So that I think I've addressed that before. So there's a lot of scientific debate around that. I don't know if it's true or false. It doesn't matter as far as the policy goes. Because
please carry on. Sorry.
Yeah, so yes, Seychelles has 7 deaths since made. I mean, the vaccines have worked in Seychelles, as far as I'm concerned, right? It doesn't matter as far as the policy goes. The only question is, are the new variants changing the gradient of the risk from disease from age? And the answer is no. And there's no evolutionary reason to think that it would change the age gradient of risk. So, as long as the answer is no, the vaccines, you should still use them for focused protection.
I think Dr. Alok Rai, I think he's waiting to ask something. Dr. Bose?
Yeah.
Is Alok is here?
I don't know. He has not put anything in the comments. Yeah, he is there, but he has not put anything in the comments.
I hope he'll be asking something, or maybe we can discuss what he said.
Dr. Alok Kaur, are you there?
I see him, but I don't see his, he's muted right now.
Picture. So I don't know whether he's active or not. Is there any other questions? I think Dr. Mangulik raised a comment, which obviously you're in the middle of talking about. Oh, there's one other question. I'll come back to the second one first. It's Dr. Mangulik says, and there has been reported 7 COVID deaths in Seychelles, which is a lovely, beautiful part of the world, in May 21. I still remember the days of Mahe and Ladig. Those are beautiful areas. So until now, what have you got to say to that?
Yeah, I mean, I think 7 deaths is not if I understand, the Seychelles have vaccinated a very large fraction of their population using I don't know. I think it's neither the mRNA vaccines, and nor is it, I think, even the AstraZeneca is not a large fraction. That's maybe a small fraction of the AstraZeneca. I think they're using one of the Chinese vaccines. I think those vaccines I don't know the data on those vaccines, but my guess in the Seychelles is that those don't protect against transmission, but do protect against severe outcomes. And so the fact that there's 7 deaths suggests that it's actually been effective at protecting against severe outcomes. And so Seychelles gives, as an example, we shouldn't expect the vaccines to stop case growth. What we should expect the vaccines to do, if they're deployed correctly, is to protect the vulnerable.
Professor Jai, sorry, Dr. Das, I probably has a question. Yeah, I'll speak later.
Oh, sorry, Doctor.
I just want to know, are there any studies that validate the idea that these vaccines reduce the severity of infection, prevents hospitalization, death? Are there any standard studies across the world? Can you enlighten us?
Yes, there are. So we heard from Dr. Mukherjee, I think, earlier about the experience in the UK. The same thing has happened in Florida. The same thing has happened basically everywhere where the vaccines have been deployed. In Israel, you see a very now after a burn-in period, after a couple of like maybe after a month or two, you see a very sharp decrease in the severe cases. Now this is not a study I can show you because I'm not done with it, but I've been working on a study in the United States to track by age who's been vaccinated first in different states. And what you see is a sharper decline in those age groups that had preferential vaccine policy. Like in Florida, for instance, the nursing home deaths declined earlier than because they were vaccinated first relative to people that were in their 50s or 60s. So the timing of the vaccinations correlate with the decline in the number of cases, the number of deaths and severe outcomes, hospitalizations? I think the answer is yes. The other thing is that you saw this also in the randomized trials, Dr. Das. There was a huge decrease in the number of vaccination, the number of deaths and hospitalizations in the vaccinated group relative to the placebo group. It would be very surprising if you didn't see that in the real world also.
Professor Bhattacharya, if I make a comment on what you have said, and this is mainly to you as an economist. You are also a very renowned economist, I know. Your understanding of the economics is very deep. So my observation is vaccine also has created a huge market. And this market has been created, just now you have also said, that this is a kind of market which has been created out of fear or marketing or promoting apprehension about the epidemic. So there is an economy of apprehension that has been operating in this globe for a number of years, as you know. And my question is now, say IMF, I understand that IMF has taken a policy that they will go for mass vaccination, and they have asked for $50 billion for this, which probably will be allocated by cutting different other promotional activities or other activities. Now, $50 billion is a huge market. My question is to you. Now, again, there will be controversy on what type of vaccines are more effective and what type of vaccines are less effective. For example, the institutions who say that probably the vaccine was not that effective. Now, we are also listening to different questions and different discussions on vaccine passport. For example, many are saying that now in India, the COVID vaccine that if someone takes, he won't be allowed to visit US and other Western countries. Now, that is a real problem in future in case. Now, if there is a huge market for $50 billion for vaccines, and there vaccines like COVID or other vaccines from other developing countries are not recognized by other developed countries, what will be the outcome of that policy? So there should be a scientific body, apart from WHO. WHO are probably bogged down with many other issues, who should ratify which vaccine should be taken and which vaccine should not be taken. A kind of mutual recognition should also be there. And I think I would expect your very important comment on that.
So, Dr. Day, I think first, let's just return to one scientific point. If you were previously infected but don't have the vaccine, it's effectively as if you were vaccinated.
Okay.
So a policy that ignores previous infection but acknowledges vaccination is a discriminatory policy, right? It's an irrational discriminatory policy that's against the science. So that's just as one very quick comment. The second thing, just very broadly, I think that a policy that requires this kind of sort of mutually agreed kind of vaccination in order to travel, we've seen enormous benefits from globalization of sort of interactions between populations across countries. A policy that moves in that direction toward these requirements for vaccine passports will tend to decrease those kinds of interactions, and I think we'll have enormous. We'll tend to retard the growth of economic cooperation around the world. I think somewhere on the order of, hundreds of billions of people have been lifted out of poverty as a consequence of this kind of economic cooperation. And slowing that down, I think it won't hurt the rich, because the rich will just buy the vaccines. Well, they'll get the vaccines. It'll hurt the poor, because it's not that the poor travel to the United States or elsewhere. It's that they benefit from the growth in global cooperation, economic cooperation. So I think that policies, I think in general, the policies along those lines are dangerous policies that you have to think very carefully about, those kinds of vaccine passport policies. Now, I think they're also not necessary in this case, because what problem are they solving? Well, the idea is that if I travel from the United States to India, I might introduce the California variant to India, right? That's the problem they're seeking to solve. But if the older Indian population is already vaccinated, then they face no risk from me traveling. There's no externality I impose on them because they're already protected. And vice versa. If my cousins, I have so many cousins and uncles and aunts who live in India, I actually live near Kolkata. If they come visit me, do they pose a harm to me? Well, no, I'm already vaccinated. The idea, I think, that economists use to justify these kinds of policies is one of externalities. But I think that externalities are essentially undercut if people get vaccinated themselves. So I'm 52. I don't need to worry about that 0.2 risk anymore because I'm vaccinated. I no longer face an negative externality from being around others who might be infected. And so if you've undercut that externality, the harm from the externality, I don't think there's any economic justification for a policy like that. And I think there's potentially an enormous economic harm, which the poor will face.
Exactly. Exactly. Yeah. Thank you. I think you, the scientific community, the scientists, the economists like you, would also like to include that as an appendix or add on to your Great Barrington Declaration, because this is going to have a tremendous impact on the future of lots of people who travel across the globe as a worker, as a migrant, and also as a business traveler. So please look into that. And from the developing countries' perspective, if I argue, countries like India, suppose they have developed some vaccine, it may lose its own market, because this vaccine is not being recognized. So from that aspect also, I think but a stronger voice from scientific community across the globe on this issue is very important for us.
Dr. Day, if you want to write together on this, I'd love to. I've written against the vaccine passports.
Yeah, thank you very much. I would love to. Thank you very much.
Dr. Chakrabarti.
Yes, I have a question. Vaccine makers have asked for immunity against litigations arising out of adverse reactions, even deaths, if accorded to the vaccines. Your opinion on that, please.
So that's been provided in the United States. I am in favor of it. And I'll tell you, in general, not in a general sense, but in a particular sense for this. I think this is an emergency. And the normal time, the procedure to test the vaccines to the full extent so that it would get approval is not time for that. When we're facing such a large number of people, elderly people who are at risk. So to me, it's a question of balance of harms and benefits, right? So the vaccines, I think, are mostly safe. I'm not fully confident of that because they haven't been tested for years like many other vaccines have when they're deployed at population scale. For the older population, I know COVID is not safe. COVID is a deadly disease for the older populations I showed you. So the balance of benefits and harms for the vaccine in the older population are so clear. COVID is deadly, and the vaccines may or may not have some safety issues, but for all indications are pretty safe. And so for them, it makes complete sense to cut short the long process of evaluation and say you should use them. Now, from a vaccine maker's point of view, if the fact that that there may be some safety issues that are discovered over time prevents them from deploying the vaccines in this older population, well, that will cause enormous economic and medical harm. And so I'm in favor of reducing the liability to vaccine makers so that it can be deployed in the older population. Right. So in the younger population, the argument's a lot harder, right? So in the younger population, if you have, Dr. Chakrabarti, if you have long-term side effects of the vaccine. Well, I mean, does it need to be deployed in children when COVID is so low risk in children? So I'm not decided on that fully there. It would depend on whether it's possible to have a conditional approval or conditional liability where you say, okay, if it's the older population, you have no liability. If you're younger, you have some. It's harder. I don't know the law or the legal situations well enough in different countries to say whether that such a kind of conditional liability would be possible.
There is one thing I want to ask you is this natural immunity is for a long time. By
Yes.
natural immunity, this vaccine immunity, we're not sure exactly. Some are saying 2 is enough. Some saying you give a third within a year or something like that. What is your views on that? And
Well,
I mean,
nobody knows, right? Nobody knows how long the vaccine immunity lasts. I've seen some evidence that that it induces a pretty wide reaction against a wide set of epitopes in the spike protein, and the T cells and other mechanisms of immune response are pretty robust. So if that's true, the vaccine immunity is likely to last a good long time. But the answer is still we don't know the answer. We don't know yet. The immunity from natural infection is very robust. It's lasted a full year or more, right? And still ongoing. So I think, I mean, in many ways, this is not HIV where it evades immunity. This is much more like a coronavirus where you get some lasting immunity from it, and even longer lasting protection against severe disease.
Professor Bhattacharya, may I ask on behalf of Mr. Alok Kaur, whose exercise we have mailed you actually, that's a very preliminary scatter, which gives only an association. Here in India, we don't have enough data. Can you please suggest the possible data points and data exercises that we can do?
Okay, so let me put this up.
Otherwise, it could have mean that vaccination makes the second wave.
Yeah, so I saw this is the slide deck you're talking about, right?
Yeah.
And so let me just say, so let me give some comments about this. So I think that this is in some sense very careful. So you see this like let's see if I can you see the slides? The efficacy of COVID vaccines. What do the numbers say? If I understand the slides, what the slides show is that the vaccines, when they were put in place, this blue line, the second wave nevertheless spread through India, and the vaccines didn't stop the spread of the disease through India. If I'm understanding the main upshot, and this is interesting evidence. The main thing about this kind of evidence is that you have to understand the numbers and the populations to really to make sense of this kind of correlation. So in each of these places, you're seeing a very large number of people vaccinated, but still a very large number of people not vaccinated.
Right.
You're also seeing a very large number of, so, you know, I said 40% of the Indian population over 60, 40% of the doses of the vaccine went to people over 60 in India. India has, I think, 6 or 7% of its population is over 65. Well, that means that the older population did preferentially get the vaccines, just not at higher rates as I would have wanted. So in order to do this carefully, what needs to happen is you need to check. Let me stop this. I'll answer the questions, by the way, in just a second. You have to check whether the age groups that were preferentially given the vaccines what happened to the cases among them. So you need some sort of like difference in difference strategy where you take a group of people who weren't vaccinated. Maybe the poor population wasn't vaccinated, whoever wasn't vaccinated, and ask whether they had a higher rates of infection, they had higher rates of disease relative to the people who were vaccinated. You need a control group. And the problem with this kind of analysis, it doesn't yet have a control group. It's an interesting correlation, but it's not surprising in some sense. There's 1.4 billion people in India. The vaccine was spread out to about 120 million. That's less than 10% of the population, right? So the fact that it didn't stop the spread of the disease is not, in some sense, that surprising. So let me answer the questions specifically in there. So the questions are the vaccines capable of checking infection growth? I think probably is the answer to that question. I don't know for sure if it is or isn't. I think as long as if for most of the vaccines, the answer is yes, that I've seen, with the possible exception of the South African variant. Second question, can these prevent severe COVID ailment of the vaccinated? The answer is absolutely yes, and that's true for all of the variants. Third question, are the chances of breakthrough infection high? And I think the answer is no. The answer is no in the following sense. You're not, if you are reinfected and you've been vaccinated, you're very unlikely to have severe outcomes. You may still have an infection, but but it will be an infection that's very mild, and you're less likely to spread the disease. The breakthrough infections, look at natural immunity. I mean, there's very few breakthrough infections. The rate is less than, after a full year, less than somewhere in the order of like 1 in 10,000 or 1 in 100,000. Right, so it's very, very low likelihood. Okay, so let me put up this last slide, because I think this is the slide. This is from this question, right? So, right, there's no report in Lakshadweep. There was no reported COVID deaths till late April. No tests until January 21st. The vaccine started spreading, and then the disease started uptick. The problem here with this kind of correlation analysis is that there's many other things that could be going on. In particular, I think for places like this, and in fact, all through India, the key question is like, one of the key questions is seasonality, and as already addressed, who was vaccinated, in whom did the disease spread? You need more micro level analysis to make this kind of work convincing. And finally, is there any possibility that a vaccinated person may infect others? I think the probability is almost zero, very, very close to zero. It's not zero, but it's very close to zero.
Thank you, Professor Bhattacharya.
Sure.
Any other questions from anyone before we call it a day? Any other questions or anyone
like
wants
Dr.
to
Das
clarify anything?
Dr. Das, please.
Without regular approval, is this advisable or ethical to put these vaccines on a mass scale, to vaccinate large group of population without regular interval? Is it ethical?
Yeah. So I think it needs to be evaluated very carefully by regulatory authorities. So without that, there needs to, I would say you shouldn't do this. I think, to my mind, the answer to that question depends on the risk that you're preventing. So for the older population, I have a lower threshold for the regulatory oversight needed before you say yes. There has to be some, but there has to be, I'd say much less. For younger populations for whom COVID is much less risky, then I would ask for much more severe, or much more in-depth regulatory oversight.
Stringent, yeah.
Stringent, that's the right. Thank you. Yeah, I mean, I think that's the right way to think about this. So the ethics of this depends on the balance of benefits and risks.
Any
other questions?
Then, yeah.
Actually, there are plenty of questions in Facebook, but I think most of them are covered, and which are not. For those, Professor Bhattacharya already told that he is not sure. So I don't think we have any point in repeating them.
So before we conclude, I would like to thank Professor Bhattacharya for giving us Sunday morning nearly. It should be 11 o'clock by now, 11 or 11:30 at your place, when you should be relaxing with other things or household chores that might be more important, for giving us the time and enriching us with the knowledge of the subject which we are vaguely aware but not fully aware. And before I conclude, I would like Dr. Stobit Dasgupta to add in a few words.
Well, thank you. Thank you, everybody. But I don't have anything to add after what Professor Jay Bhattacharya has told us. We have been enough enriched today, and we shall think over it. We shall try to do whatever is possible today. Thank you very, very much.
Then in the sense, Professor Bhattacharya, have a lovely Sunday. And for the other people who are nearly, it's about 11 o'clock in this part of the world, have the rest of the time you can enjoy with whatever you want to do before you go to bed.
Thank you for staying up so late for me. I really appreciate it.
Oh, we really appreciated the thing. It's not saying up late. We really appreciated it.
Oh, thank you actually for your time to this web discussion. And we hope we can get in touch in further developments and we can update you and get updates from your part too.
I would love that. When I come visit, we can have Holland Bath together.
Sure. Sure. Thank you.
Thank you.
Thank you very much.
Have a nice day.
Bye-bye.
Bye.
Bye.